Hi, everyone. My name is Ashley, and for my presentation, we're going to be focusing on the kidneys. We're starting off with some external anatomy here for our first slide, and the diagram here shows a posterior view of the kidneys. So as we can see, they kind of sit at the bottom of our rib cage between T12 and L3. The right kidney, it's slightly lower than the left kidney. That's because we have the liver right over top of it. So it's down a little bit further just to accommodate that space. And the kidneys are also encased in 3 different layers. So they are directly encased by dense irregular connective tissue. This is to help maintain their structure. And then after that, it is covered by a renal fat pad that serves as cushioning protection. So again, it's kind of like a pillow just to keep them nice and protected, since they are kind of towards our back and right up against our back and ribs. And then after that, they are ultimately encased by renal fascia, which helps anchor them down into the posterior abdominal wall. All right, so getting into some internal anatomy of the kidney, we have the entry and exit site of the kidney, referred to as the renal hilum. This consists of the renal vein, renal nerve, and renal artery. Something to keep in mind, the 2 major blood vessels for the kidneys are the renal artery and renal vein. And starting from the left top, we have the cortical blood vessels, the interlobar blood vessels, medulla, ureter, which is where the urine will exit to and then go into the bladder. We have a capsule that encompasses the entire interior of the kidneys. We have arcuate blood vessels, the minor calyx, major calyx, renal pelvis. So the major and minor calyxes will drain into the renal pelvis and eventually into the ureter and into the bladder. And we also have papillae, the renal columns, which are between our pyramids here. So we can see them between each and every triangular portion. So this video here does a really good job of explaining the path of blood through the kidney, how it is brought in through the renal artery and then traced all the way back out through the renal vein.
The nephrons of the kidney have a unique blood flow. So if one were to trace the flow of blood to a nephron and back, say beginning with the abdominal aorta, one would follow the renal artery as it enters a kidney, and the renal artery then branches into 5 segmental arteries. And in the renal pelvis, these segmental arteries will divide into several interlobar arteries. These interlobar arteries form arcuate arteries as they arch over the pyramids in the renal medulla. And from these arcuate arteries, cortical radiate arteries then approach the cortical tissue. Afferent arterioles depart from these and enter the renal corpuscle, forming the glomerular capillaries. Now, the glomerular capillaries are drained by efferent arterioles. Nowhere else in the body are capillaries drained by an arteriole. These efferent arterioles then form a second capillary network. Either the peritubular capillaries around the PCT and DCT, or the vasa recta, which surrounds the loop of Henle. These capillaries then drain into cortical radiate veins, which drain into arcuate veins, which drain into interlobar veins, which drain into segmental veins, which drains into the renal vein, which departs the kidney.
All right, so this is a still view of the path of blood through the kidney and into the nephron. I have the glomerulus and Bowman's capsule here. Another term for the glomerular capsule is the Bowman's capsule. So together they form a renal corpuscle. And then three major processes for the nephron are glomerular filtration, tubular reabsorption and secretion, and then water conservation. And then this is done in three different sections. All right, so filtration begins at the glomerulus and Bowman's capsule. Blood will go into the glomerulus from the afferent arteriole, which is slightly larger than the efferent arteriole, where blood will then exit the glomerulus. But blood is rushed into this region here, and osmotic pressure builds, where solutes are able to be pushed out, and then blood isn't, and then will exit through the efferent tubule. This is done by several mechanisms. The whole nephron is controlled through feedback mechanisms, whether it be autoregulation, sympathetic, or hormonal control. And so this is kept in a stable state where glomerular pressure is either controlled either through constriction or dilation of the afferent tubule, so that it will control how much blood is coming in at a certain point, whether it has to be a lot or little. It controls that mechanism that way. And roughly about 150 to 180 liters per day are filtered, and only 1% of that is actually urine. 99% of that is reabsorbed through the renal tubule. So how is this done? The afferent arteriole exits Bowman's capsule and branches into the peritubular capillaries that surround the renal tubule. And so we move into the proximal convoluted tubule, where 2/3 of reabsorption happens. Epithelial cells lining the tubule into the extracellular space. So this is taken up by peritubular capillaries. And then sodium reabsorption is important for the osmotic pressure in order to push water and create a concentration gradient. So stuff that is also moved out is glucose, aminos as well. All right, and then secretion and reabsorption continues in the nephron loop, also called the loop of Henle. And this is formed by the loop of Henle and the distal convoluted tubule. So the loop of Henle creates and maintains osmolarity gradient in the medulla that is enabling a collecting duct to concentrate the urine later on. The ascending portion, so the left side of the loop that we see here, pumps sodium out, while the descending portion is more permeable to water and not so much sodium. So it's kind of keeping this balance here. The ascending portion is more permeable to ions, and it loses sodium, making the filtrate more diluted. So as it's coming down, the descending portion is becoming more diluted, then up, once it's coming right back up, it's becoming more concentrated again. And it's all doing this to kind of maintain this pressure and concentration. The distal convoluted tubule portion is controlled by hormones. So that's aldosterone and parathyroid hormone. The collecting duct receives fluid from several nephrons at a time. So we see all the way to the right here, these kind of little branches. This is where other nephrons would be collecting or connected to, then to dump into the collecting duct. And so the collecting duct is controlled by antidiuretic hormone. So this kind of controls how much water we are also excreting with our urine. So if someone were to be a little bit more dehydrated, water is going to be reabsorbed in the collecting duct and less is going to be expelled, versus someone who is hydrated, where more water will tend to be secreted. Okay, so this final video here goes further into detail about the formation of urine, talks a little bit more about how the concentration is maintained versus whether it be water
The
being
kidneys
expelled
filter
or sodium.
glomerular
just to keep the concentration
filtration.
gradient stable. And then these are my references that I used for this presentation. All the diagrams were used from the OpenStax textbook, and there were 2 YouTube videos that I used as well.